So I think we encounter the consequence of the pink pulseless hand in two situations. One is the patient when they first arrive in the question that we had at the start of the talks this morning, and the other is when we don't have the pulse after we have done our reduction. And so I'll talk about both of those aspects. So we all know the scenario. 1 o'clock in the morning, 8 p.m. at night, we still have to make that decision. When are we going to go to the OR? What do we base our decision upon for that? Do we have a pulse? I think that's our number one thing that we look for. Can we feel the pulse? Do we have a nerve injury? We know that the most common nerve injury is the anterior interosseous nerve, and so we're looking to see whether they can bend the thumb at the IP joint, bend the index finger at the DIP joint. And then if we don't have a pulse, but we've got a pink hand, is it a good enough pink hand to observe overnight, or should we be taking that right away to the OR? This is a paper that we published from Boston just a few years ago in the Journal of Hand Surgery, and it helps to answer both of those questions in our practice. We're looking for the perfectly pink hand, so it has to be pinked the same as the other side, even if you can't feel the pulse. The pain has to be well controlled, so we're worried about compartment syndrome or Volkmann's ischemic contracture from ischemia of the flexor compartment. And the reason why we're so worried about a nerve injury is because not only do we know we've got a more severe injury, but we also potentially, the patient won't feel the pain from the volar ischemia to the muscles, especially if their anterior interosseous nerve is out. And that's why we're so focused on making sure we know whether or not the anterior interosseous nerve is functioning. If we choose to observe overnight, then we frequently observe that patient, and at any time we will change the plan. So they have to be observed at least every 1 to 2 hours overnight. Otherwise, if we have any doubt, we just take them to the emergency OR overnight. We've talked about the vascular injury. Most of the vascular injuries are actually not complete disruption of the artery, although I have seen that. Most of them are kinking. So we'll go through the algorithm that we use. We look, do we have as the supracondylar fracture with an absent pulse? We know we need to reduce and stabilize that fracture, but we don't need to do this one. Do we need to do it immediately, or do we need to do it in the morning? And we went through the 4 things that must be present if we're going to wait until the morning. If we've done our reduction and we still don't have a pulse, that's a much harder question, and I think that people are a little more divided about what we should do. If the pulse has returned, we've got a pink hand, then we're happy. If the pulse has not returned and we have a cool or a white hand, we know that we have to assess our fracture reduction and go down the pathway of returning the vascularity, because if the hand is pale and the pulse is not there, then we have a vascular injury. The treatment algorithm is much, much harder to decide what to do when it's pink, but the pulse is not present and our fracture is well reduced. This is where we, in our institution, will use a Doppler ultrasound, just the little handheld one, not the 3D, graphic one, to listen to the pulse. But if you don't have that available, you have to then use your clinical judgment for that. We have found that most commonly that this will be due to a kinking, just like the ulnar nerve palsies are due to fascial bands. It's most commonly due to kinking of the artery. It can be entrapped within the fracture site, or the fascia can be trapped in the fracture site, causing the constriction. We know that if you observe a number of these patients for a long period of time, their pulse will come back. However, we also have found that there's a high incidence of actual vascular injuries when we look at these patients, and a number of surgeons have also found this and has collaborated with this through Posner. We therefore have a very low threshold for actually openly exploring and decompressing the artery. And we will do this through an anterior approach because that's the point at which the artery is injured. There's no role for angiography. We know where the injury is. We will do a decompression and, if need be, a repair, and we'll immediately move to that dependent upon the return of circulation and a pulse to the hand. We will use a vein graft in order to do that, and we find that and we have looked at our results in follow-up and they remain patent. So in conclusion, with a pink pulseless hand, if you're going to observe, then it has to be perfectly pink. It has to be the same as the other side. Any compromise in the vascularity, then we worry that the patient will end up with an ischemic contracture. We personally have a very low threshold to explore, and that it's commonly an extrinsic compression. Thank you.